The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thanks so much to ChiroHealthUSA and to Christy for having us present here again today with the folks. We really appreciate it. We've got some exciting things to go over today, some new research studies, as well as how to better prepare our report of findings utilizing radiographs to validate care. So first, I must do the proper disclosure, and that is I do have a relationship with a digital x-ray company, Biokinemetrics. I'm the president of that company. However, today's webinar is regardless of whatever x-ray system you have, the information is research-based, it's evidence practice-based. So after making that disclaimer, we could go ahead and move forward. So let's start off first with, in order to use research, in order to validate the necessity of care, we first have to base our decision on taking those x-rays on chiropractic necessity. But in addition to that, using evidence-based practice, you have the ability to have a three-legged stool. And that three-legged stool is designed to take into account the patient's preference, the published research literature, and your own clinical experience. And using evidence in your practice allows you to keep that clinical integrity, get better outcomes, make smart decisions in your care plans, and follow the necessary protocols in obtaining those x-rays. So most of you who've been in practice a number of years realize that about 10, 12 years ago, evidence-based practice, or EBP, was the buzzword that was out there. And kind of one of the godfathers of that definition came from a Dr. David Sackett. And he states that it's the conscientious, explicit, and judicious use of a current best evidence, the best evidence you have in making decisions about the care of the individual patient. So what do we really mean by all of this? Well, the clinical evidence can be published. Your clinical evidence can be your experience. And then, of course, patients also have the right to weigh in. Do they or don't they want to have radiographs? So one of the detailed definitions in evidence-based practice goes a little bit deeper. And this, as I said, this is back in 2002. So I've quoted Sackett just recently this year, and then we go back 16 years to what he said when it first kind of came out. And basically, if you use the best research evidence in your decision-making process in determining the care of the patient, and then clinical expertise, this is important. Clinical expertise refers to the clinician's accumulated experience, your education, your clinical skills. So the patient brings their own encounter and their own personal preferences, their own unique concerns and their expectations and values. They bring that to the table. And so we're not supposed to, as clinicians, base everything 100% off of a published research study. That's just 1/3 of the formula. So to simplify this whole thing, it's what's the best research evidence out there? What's your clinical experience as the doctor? And what is the client or the patient's desire? We take all three of those things and kind of make this three-legged stool our evaluation. So there's going to be situations, especially on that new patient exam or on an established patient, where the patient is pushing you, they want x-rays. And if there seems to be a valid reason for it, even though you might not have all of the research there, but if your clinical experience combined with the patient's values and preferences lean towards taking that x-ray, by all means you can do that. And we're going to talk to you today about some published research evidence, but you're also going to find, there's only so many studies out there, so there's not a study on every single condition, and a lot of the studies that are published are hogwash, and some are good. And so you can't base it all on the published literature because there's not mounds of it out there on every single condition. And today we're going to talk about some basic ones when it comes to low back pain. But in your process of evaluating first, before you can deliver a report of findings, we've got to first establish the necessity of those radiographs from the beginning. So once you have that evidence, you found that evidence, and we're going to share some of that with you today. And then you have to kind of integrate that evidence with your expertise and those patients' preferences and evaluate it and just kind of make a decision. You know, Duke University actually came out with a 6-step process for the evidence-based practice. And it does start with the patient. You know, we're going to assess that patient, established or new, and what kind of questions arise. And we need to ask ourselves some clinical questions derived from this case and use the appropriate resources to make that decision. We validate it, then we kind of look back to the patient, we integrate that evidence, that expertise, see what the patient's feelings are about taking those x-rays, and then you'll do it. And then later you evaluate, was it worth it? Was it important? So I'm going to just start with the old phrase, if a picture says is worth 1,000 words, well, we got to make sure that our images are the best. So when we're dealing with patients, we want to have a modern practice and we want to utilize clean, crystal clear images. And one of the things we talked about today, that we're planning on talking about today, are biomechanical measurements. By no means does every chiropractor use biomechanical measurements. Certain technique groups do more than others. Using your own, just your impression, whether you're doing a biomechanical measurement or you're eyeballing it, you know, is that pelvis tilted? Is that cervical curve reversed? You know, we also need to look at normal aging findings. So if you have a 7-year-old patient and we see some bone spur, disc thinning, well, to some degree, we expect that at that age in certain patients. But is that a normal finding on a 22-year-old or a 30-year-old? It depends on what their history is, what kind of injuries they've had, how is that condition advancing. I'll challenge each of us never having a baseline x-ray on a patient. And if a patient's never had an x-ray in the last, whatever you feel your clinical experience tells you, whether that's 5 years, 10 years, 15 years, whatever it is for you in your experience, because there isn't enough research on that question I just posed to you, but having a baseline helps guide your analysis in the future, knowing whether or not this aging process is on an accelerated pattern or if it is kind of the normal wear and tear. I'm going to use myself as an example here. This is not my x-ray, but I'm just going to show you a lot of biomechanical measurements here. I'm certainly not suggesting everybody needs to do this. I'm just giving an example, but I can tell you that I had a normal cervical curve my entire life until age 51. I'm now approaching 55, and I just took a set of x-rays of myself last year, and in that 4-year window, I developed severe degenerative changes. In a 4-year window, I had 0 degenerative changes when I was 50 on my cervical spine. My point is, to me, it was an alarming acceleration. And I know the trauma that I had that resulted in it. So I'm just sharing with you, if you don't have the full history of the patient, you can't just assume a bone spur degenerative changes is just normal if 5 years before that they had 0. And I'm a living example of that. So we kind of go back again. What's your expertise? What have you learned over the career that you've had? And you have to use that. So if you've looked at, thousands of x-rays over a 25-year career, that might be a different set of clinical expertise than somebody who's got 3 years of experience. I see some young docs writing papers and posting them on the web on how they're just fine not having x-rays. And they've got a few years under their belt. It's a little different. And some doctors out there have seen thousands of patients, different individuals, and some have seen, maybe a couple hundred. It's a different level of clinical expertise. So let's take a look now, uh, basically at some studies for low back. We'll start off with that first. And how do these studies help shape your report of findings? How are you going to use them in the report of findings? So one study based on degenerative disc disease. So certainly, as we gave an example earlier, on a 60, 70-year-old individual having some degenerative disc disease, even on males over the age of 50, some of that is expected. On the other hand, this study shows us that there is an intimate relationship with degenerative changes in the lower lumbar levels when you take a look at flexion extension radiography, doing flexion extension lumbar films. And what they showed was that if there was some anterolisthesis or retrolisthesis, some instability, there was a significant relationship with degenerative disc disease if they had that. So if flexion extension views result in no forward slippage of L4, L5, or no retrolisthesis on extension, there wasn't the same degree of degenerative changes there. And again, you wouldn't know that if you didn't have those images. And so basically, the authors of that study, they were looking at prior studies and they found a lot of flaws in the prior ones. So this one that was published showed that if the lumbar lordosis was highly abnormal, and if it was out either hyper or hypolordotic by 7 degrees outside the normal, there was also a clinical indication of degenerative joint disease. So I thought that when we read this study, that really only having several degrees outside of normal was a predictive factor in that person getting degenerative changes, lumbar degenerative disc and vertebral degeneration findings. So it's important to know what is the lumbar lordosis, and it showed that men over the age of 50 had a much higher prevalence or predictive factor in that study, and that was published just last year in 2017. So this is a fairly new study, and it showed that almost a 95% correlation with abnormal lordotic spines and the correlation to degenerative disc problems. And for female, it was almost at any age that they had hyper or hypo, they were going to get it. They were going to get changes. And for men, it was kind of over the age of 40. So Johns Hopkins Medicine, on their website, they talk about how x-rays of the spine, neck, or back should be performed to diagnose certain kinds of conditions, and things like kyphosis of the thoracic spine, scoliosis. So if your postural evaluation on a patient is showing in the exam, one shoulder is significantly higher, the pelvis, when you place your hands on the iliums, visually appears to be higher, x-ray can be warranted to make that determination. Is a possible scoliosis present? And so how do you know? You don't know unless you take the image. So if that pelvis is tilted, what happens if you do a postural assessment on a patient? Do you really know how long they've been walking around with a tilted pelvis? Maybe they've been walking around with that tilted pelvis for a decade. Maybe they've been walking around with it for 3 days. Until we take that image to see if wear and tear changes on the shorter side, on the convexity, on the concavity side, then you've got an idea how long that's been there and what kind of corrective action, or is it even possible to make a corrective action on some of these cases? So we've talked about scoliosis, but hyperkyphosis of the thoracic spine. Again, you could observe if there's a postural issue. Do you want to take that to see if there's anterior compression going on? Even though patients often don't recall trauma, an x-ray sometimes jogs their memory. If you discover an old compression fracture, you discover wedging. In this case, I'll give you an example of my brother-in-law. He was 42 years old. He came into the office. He was riding a lawnmower and hit a big bump, big thud, kind of a 6-inch hole, and, jarred his back. And, he's one of those physical worker type guys. So, rough, tough cookie, and does a lot of manual labor for a living. Comes in and just, he wasn't complaining heavy. It was kind of his normal back issues. Came in and, he had a little tenderness there, but again, nothing was jumping off the page. We hadn't had an x-ray on him in a number of years, and we said, I suggested we take one, and this is his x-ray. We found a compression fracture in a 42-year-old guy riding a lawnmower. And you wouldn't normally suspect such a thing from that activity. So you never know. How prevalent is a spondylolisthesis L4, L5? Does it impact your care? Would you still adjust L5 if it had a spondylo, depending on your technique? What if you've been doing side posture on a certain patient for over the years, and you've always wondered why maybe on that left side it didn't go as good as the right, or let's say it never went. And later you take an x-ray and you discover, oh my gosh, they've got a spatulated transverse process or a fusion of a transverse process to the ilium. I've seen this, and granted, I'm not saying this is an everyday occurrence, but am I suggesting we start taking x-rays on everybody to look at anomalies like this? No, of course not. But just because a patient isn't complaining of significant pain, having a baseline image, if we're going to hold ourselves out to be a spine care expert, how are we to be a spine care expert if we never know what the spine looks like? At some point, if you're treating patients for multiple episodes over the years, at some point I would think an x-ray makes sense. We can't always just say, well, it's just recurring. I adjust a little bit, then it's better. And then 2 months later, they come in, they need a few more adjustments. If you're doing this for years, I really think having an x-ray is important, because another x-ray several years down the line is also important. I will say it this way. If one of my children, I've got 7 kids, and if one of my kids had a postural shoulder tilt and pelvic tilt of a minor degree, and I didn't know a lot about chiropractic, and I went in and they checked the posture and said, okay, let's do a few adjustments. Hey, they feel good. They're not complaining, and they look kind of level now. And then 3 years later, I come to find out they've got significant scoliosis. Do you think as a parent, I'm going to be upset at that prior doctor who didn't take x-rays, where we lost out on years of preventative care or even home recommendations? Because a picture is worth 1,000 words. It has more value. In today's here today, gone tomorrow society and all these news bites, and we get busy with life, if I'm in your office and you're giving me, the father of my 13-year-old daughter, a report of findings, and you're just saying, yeah, the posture's off a little bit, it looks pretty good now, we want to watch it and make sure this doesn't happen, let's do some periodic adjustments. And then let's say I go to this orthopedic surgeon later because for a different reason, and we discover, oh, by the way, your daughter's got scoliosis with a 15-degree curve that wasn't detected that significantly from postural assessment, but there were some indications, but you, the doctor, felt it wasn't enough or warranted to take the x-ray because the posture really wasn't that bad. It was just a little off in your assessment, I'd be furious. That's what I would be. So how often do these bony spinal deformities and these anomalies appear? So there has been some analysis where they took x-rays that had been taken over a 10-year window, and they went back and looked at all those x-rays and counted up the anomalies. And when you round it off, it was just shy of 10% of the population. It was like 9.8, I think. And basically, some of those anomalies, the transverse process of L5 was fused to the sacrum, sometimes both sides, sometimes it was fused to the ilium. That happened in 3.5% of the population out there. Other things where wedged vertebrae or the disc is very, very thin, even on young people. That was found on x-ray a significant number of times. And the big thing is, what about the reverse curve? What's really normal? What's the normal curve? At one point, someone, 20 years ago, they said it was 60 degrees, then it was, 45 degrees, and now, normal is the average, right? Now they're saying, it's somewhere maybe around 28 degrees of the curvature. So it depends what research study you look at, how current it is, and what are we really comparing it to. Again, blood pressure normals change because here's what the population's blood pressure is. Well, here's the average. That's now the new normal. So, when we look at things like the reverse curve, I can share this with you. Most people who have reverse curves have some kind of neck range of motion issues. They have cervicogenic headaches, or they've got a lot of muscle tension on that upper trap area. And again, those of you out there who think, I can tell anybody who's got a reverse curve by just looking at their posture. And we take a look at this case in front of us at the C5, C6 level, we can see early potential bone spur formation on that inferior end plate anteriorly on C5. Wouldn't call it a bone spur at this point, but the question is, if I were to tell you that this was an 18-year-old and we see this kind of slight bone deformity starting to change the shape, as an 18-year-old, if you show me this picture and go over how my posture should be, how I should sit at the computer when I drive, my head forward carriage, makes such an impact, going over different postural corrective exercises to help with this, as well as, some adjustments to get them on the right path. If I, as an 18-year-old, did not have somebody explain in detail what it could lead to over the next 10, 15 years, and in some of these cases, the reversal's worse, I need to understand the significant impact of this so I take your recommendations seriously. Otherwise, I'm sitting there listening to you, the doctor, and I'm just thinking, okay, whatever. How do you know? You don't even know what my spine looks like. You're saying things to me about good posture and whatever, but it's not sinking in. It doesn't have a lot of deep meaning to me because you're just giving me a bunch of blather. And that's all it seems like to an 18-year-old. Seeing is believing. So what do? We've got to look under the hood in a lot of these cases. Again, we're certainly not saying all patients need this at all, but in a report of findings, it's important you share what do the studies say. It's important you have a good understanding of what is normal, and just because they're abnormal, does that even mean anything? It may not mean anything. Certainly having an abnormal spine, you can lead a quality of life. You can still live just as long as somebody else. But how close to normal, how far away from the normal variant does it start to become significant where this patient really needs to take this more seriously? And again, I'm going to go back to what we started about at the beginning, and that's evidence-based practice. We've got to look at the research. We've got to look at your clinical experience and what is the patient's preference. So when you're in that initial exam, you could give your opinion on the need for x-rays. You could base that opinion on some studies. You could base that opinion on your expertise and clinical experience and explain those two things to the patient. And then you could ask the patient, how would you like to proceed? And after you've recommended, X number of views and why and what the basis of it is, how would you like to proceed? Yeah, let's take the x-rays. Okay. They've made an informed choice. On the other hand, what if the patient says something to you like, well, I don't know if I want to take those x-rays. I'm concerned about this, or I'm concerned about that. Is it necessary? They might bring up radiation to you. We'll talk about that in a second. So I want to share with you a study on what the patient's percentage was on this survey that we conducted to doctors. And what did chiropractors say about their ability to annotate an x-ray with line drawings, and how did that play into patient compliance? So 68% of DCs, this was a survey on over 320 DCs, 68% of them said there was an increased patient visits due to compliance. And on the initial question, it was because of they followed the care plan better. 24% said there was no change in following the care plan. 8% said it wasn't applicable because they didn't use line drawings. On that same survey analysis, when the question was asked, what percent of patients do you show x-rays with line drawings or measurements to the patient? 56% of DC surveyed said they show over 80% of their patients line drawings or some kind of biomechanical analysis measurement. 16% said they show over 60%, 12% said they show over 20%, 12%, another 12% said they don't show any, and another 4% said they only show over 40%. So when we're sitting here talking to our patients and we're deciding what do we go over inside of our report of findings. So on the example of the reverse curve, it really depends on their age. For part of this, is every single reverse curve where they're at, is it correctable if they're loaded up with osteoarthritis, super thin discs, degenerative changes? Is it even possible to change it? Your report of findings is going to be totally different for a person with reverse curve and bone spurs for a 75-year-old patient versus a 25-year-old who maybe doesn't have the significant degenerative changes as yet. Their care plan is likely going to be different. Their outcome expectation is going to be completely different. So we have to explain to the patient, what is a reasonable outcome? Are you going to change this spine? Why is it important to change the spine? Does changing the spine going to make them feel any better? Is changing that reverse curve going to improve their quality of life? Certainly, I think it would, but is it even possible to change it on some patients? Depends on your technique. There's a lot of things to consider when you're doing a report of findings using x-rays. What I will share with you, the art, science, and philosophy of chiropractic has a foundation in helping patients better understand the care that they're receiving. Certainly we can sit here and say, well, my patients know what the outcome is because of the relief I give them with the adjustment. They don't need that x-ray. They don't need to see an x-ray. Certainly there are many cases it's not necessary. And again, I don't want people to think that this webinar is about taking x-rays on every single patient. It's certainly not the case here. What I'm sharing with you is inside your customized report of findings for each individual patient, I'm recommending to you to use the evidence-based practice model, the three-legged stool. Use research, use your expertise, explain your clinical experience on what you've seen and what an expected outcome is, and then take into consideration the patient preference. What do they expect? So a little bit ago, we talked about, well, one of the objections, and I'm going to share with you, it's rarely an objection from a patient, and I'm going to say it's rare. It seems recently within the chiropractic profession, there's a rift starting, and why there's a rift is beyond me. I believe there's a mound of research out there for many specific conditions, and then the other ones, there isn't. And you can only rely on your clinical expertise and patient preference because there's not research studies on certain conditions on the need to take or not take an x-ray. On some of the recent initiatives from certain folks pushing a recommendation out there, those 6 studies referenced, 2 of them are complete irrelevancy to the chiropractic treatment model. They don't even involve chiropractic. There were medical medication studies where they took an x-ray on a patient and then 9 months later did a follow-up. The patient only saw the MD one more time. Some didn't see him at all until the 9-month mark, and some of them saw him only once and maximum twice in that study. Of course, things aren't going to change when the only treatment rendered was medication. It didn't have an outcome. And so one of the other studies, they looked at other studies that were out there, and they didn't look at all of them. They only looked at a handful of studies on that research analysis. So there's so much flaws in the basis and the foundation of that. There's so many other ones to look at, and they need to look at them. So here's one on radiation. So Loyola University in 2015, just a couple of years ago, they said there's been some widespread statements being made out there regarding what about the radiation or the high dose rates, what's out there. So in 2015, published in the Technology in Cancer Research and Treatment, does radiation cause cancer? Do plain film x-rays cause cancer when you take it? Well, the one study that others were kind of referring to, this is the one. Even on the flawed study, it said it took about 40 x-rays throughout a person's lifetime to raise your risk of cancer by 0.05%. Okay. Now, there are so many flaws in this study. So this is the study that those who are saying, oh, be careful about radiation exposure, this is the study they're referring to, yet this study is loaded with flaws. So Loyola came back and said they came back in 2016, and then they published this in the American Journal of Clinical Oncology. And they basically said, they talked about the flaws that were used in that study, and they said there really isn't a relationship in the model that was used because that model was a theoretical model. It wasn't an actual model. So anyway, I thought I'd share that with you. Something else that others bring up, the cost of an x-ray. Well, in today's world with digital x-ray, once you've paid for your digital x-ray system, there's no more cost of film. There's no more cost of chemistry and chemicals and developer. It only takes 5 to 10 seconds to take it, and there really isn't any more cost. So doctors' costs in their practices to maintain and the ability to take x-rays is way more affordable, and it's up to you to decide. For those of you here, ChiroHealthUSA clients, you know how you can legally set up a proper fee schedule. Whether you're doing a cash fee schedule, it's up to you to decide what you're going to charge for those x-rays and images. Because if those images assist you in a better care plan, if they assist you on avoiding adjusting areas that should not be adjusted, a compression fracture, a spondylo, on the 10% of the patients out there that have these anomalies that you may or may not want to be adjusting, and the amount of radiation is so minimal, especially in chiropractic, where most of the time most chiros are taking an A to P lateral, 2 to 4 views. It's not like, when patients would go to the radiology department of a urgent care center and they're taking 8, 10 x-rays every time. The cost of radiology now is so low. I think the reimbursement rate has stayed about the same for the last 20 years and hasn't gone up that much. And these are some examples that were published on the internet from different groups that do it by zip code. So as you can see, when you take a look at what chiropractors are charging, it's about 40% less. We charge 40% less than what hospitals charge. And hospitals still charge the radiologist's read on top of that. And we're usually including the professional and technical component as one. So I just think it's important that we understand what the objections, if they're even really there. I can share with you that over my career, I can, there are double digits, right? Less than 100 in the thousands of x-rays I've taken over. I think I've taken over 10,000. I've treated over 11,000 patients. And, if I've taken 7,000, 8,000 x-rays, it's less than 100 who ever had an objection. And you just explain it. And of those who had an objection, I'm going to say 95% of them went forward with it after the issue was explained to them. And if it's financial, well, if it's hardship and financial and you feel it's that important, then go do it. Have them sign that waiver form. So what are the benefits? Well, it's about modernizing our practice. It's about getting a better first impression with patients, getting better diagnosis, and just being more sure of what's going on inside this person's body, you being the spinal healthcare expert. You know what it looks like, instilling confidence in the patient on what they've got. So that's really what it's all about. It's for better patient care. Knowing what an expected outcome can be. Because if they're loaded up with degenerative changes, you pretty much know we've got a chronic situation in many of these cases that you're not going to get 100% long-term correction going on. So I wanted to share those things with you today, and I realize we're kind of getting back to the top of the hour here. So if you do have questions, feel free to submit those. You can go ahead and send them an email, and we can get back to you on that. But I wanted to say thanks to ChiroHealthUSA for having us again. If you've got, again, some questions, or if you'd like to receive the studies that we went over with you today, go ahead and just submit your email or type in a comment saying yes, and Christy can forward that on to us here, and we'd be happy to email you the studies that we talked about today. Or you can just send an email or a phone call to this number and ask for Joan. Joan Tegas will email those studies to you. So with that, I want to say thanks again. We appreciate everybody here, and hopefully the evidence-based practice model is beneficial for you. Every patient is unique, so there's really no script to give you, but what it is, it's looking at the research, looking at your clinical expertise, and you modeling your explanations. Kind of think through those explanations and kind of have those in your arsenal when you deliver your report of findings. Thanks, folks, and have a great day.
Hello, everyone. Thank you so much for joining us today. We are so excited about today's presentation with Dr. Stephen Kraus. So for those of you who are not familiar with Dr. Kraus, he is an accomplished practitioner, author, and business owner. completed his Doctor of Chiropractic from Palmer College of Chiropractic in Iowa back in 1988. He has owned 18 chiropractic practices and is the president and founder of Biomechanical, a technology company for chiropractic focusing on digital X-ray solutions. He's also the past chairman of the Iowa Board of Chiropractic Examiners, past president of the Iowa Chiropractic Society, and has served as an ACA delegate for Iowa. His thorough understanding of this profession as both a business owner and as from a business-to-business perspective, supporting the chiropractic profession has helped him to successfully sell nearly 400 chiropractic clinics nationwide. He has been a leading and prominent in elevating the chiropractic profession through the use of technology. His past involvement with EHR and HIPAA regulations affecting health information exchange, along with his nearly 30 years history with owning multiple clinics and selling multiple practices, gives him a very unique perspective to the future of the chiropractic profession. Dr. Kraus, welcome to the webinar today. Thank you so much, Dr. Kraus, for that awesome webinar. If you would like the studies that Dr. Kraus used in his presentation today, go ahead and answer this survey. We'll make sure to get that to his team at BioK to send those to you immediately after today's webinar. Just a reminder, next week we have 2 webinars going on. We're sponsoring a webinar with Dr. Bill Morgan from Parker University on treating military and veteran populations. That is going to take place at 1:00 p.m. Eastern Time. We also have Dr. Miles Bodson doing skyrocket cash collections, even when patients have high deductibles and copays, which we know is an ever-growing problem throughout the country. So make sure you go ahead and register for those now because you know that seats will be limited. We'll be posting some more webinars, especially directed to our CA staff in the next couple of days. So be sure to go ahead and register early. So we only have about 4 or 5 webinars before we wrap it up for 2018 and start announcing the webinars that we're going to be presenting in 2019. If you have any suggestions, and I have loved every single one of them, shoot me an email. Let me know at Christy@ChiroHealthUSA who you want to hear from and what you want to learn about. I hope you have an amazing rest of your day and a fabulous week. Have a great time. See you next week. Bye-bye.